we're going to move on to the next presentation. Choki Trabalski, thank you very much, and you're going to give the floor to your counterpart. So once you've seen anesthesia, the one who comes afterwards is the surgeon. He's ready, he's there. So please welcome Fabien Calé, who is the orthopedist surgeon. So that's really the surgeon in the Garches Hospital for those doing surgery on polio patients. And he's going to open doors to some of you. Total knee and hip replacement. Long-term monitoring in a French reference center. Okay, a brief reminder, but I guess that most of you know this. So the history in Garches is strongly connected with the history of polio, with a multidisciplinary unit that was set up by Professor Grossiard with the internal medicine, pediatrics, and monitoring afterwards. And this is what makes the Garches Center to remain the reference, the historical reference center for managing patients. This is a picture that dates back the 1940s to show that the hospital hasn't changed, and we still have many patients who have grown up in this hospital and who find the known landmarks in this hospital. So we can identify two major populations. There is the polio generation that I mentioned afterwards. Most of them have retired, and most of them had multiple surgeries in their childhood. This way they can be able to walk and stay upright, and now they are facing degenerative diseases because of their aging and because of polio. I also mention this population that went through a lot of surgeries, that went through a lot of pain and traumas in their childhood. Very often they're reluctant to go back to healthcare, to the hospital, even to this Raymond Poincaré hospital. So we have to take this into account, the stress of childhood. And on the other hand, we also have people from immigration and the world population. They're usually younger, 30, 40 years old. We have few patients below 30 years old, but they are in precarious situation. They are isolated socially, and they have not had surgery and were not treated in childhood, so it's more complicated to treat them. So we'll start with the polio hips and then for knees. So we did a study between 1998 and 2020, 37 hip surgeries, and especially on the strong side. So I don't really like the term uncompensated on the other side because, you know, when you walk, you have as much weight on the strong side than the weak side. So I think that the worn out on the strong side is has a mechanical explanation because you have a tilted pelvis, and this is why there's a worn out on the strong side, and the muscular pressure on the joint. So for me, that's more the reason why the strong side is more affected. So we do a lot of scans for the possibility of doing surgery, and here you have an example of the symmetry of you have healthy muscles in light gray on the right side with a lot of arthrosis, and on the left side almost monoplegic side with fat degeneration with the darker gray. Is it the same patient? I don't remember. So in our series, we had 3 cases where we had to do a second surgery because of metallosis. In the early 2000s, we had prosthesis with metal parts. So the advantage was that the head was larger and less luxation risk afterwards. But later on, it showed that there were higher risk of complications, so that led to new surgeries. So now we have learned from this, and we don't use this anymore. what shows also the fragility of those patients. So we had one peripathetic fracture and no chronic instability and one post-surgery infection. So, for our principles, we give the favor to the anterior hiatal way, and we analyze the walk, and we do a muscular test. This is often disturbed by pain, and people lose strength when you have a painful hip. Of course, you have reduced strength on the backside. So of course we adapt our tools. So we have the a double mobility acetabular cup, and we have ceramic heads that have the advantage of having less wear and tear and less second surgery. We can also have cemented implants or not. We can have these plastic rods because of the size of the bones, and sometimes tailor-made rods when the standard rod does not fit in the hip. So one of the important principles is to respect the physiology and the muscular balance. We don't try to catch up the lack of length when we do surgery on the weak side, or we don't try to shorten the long side because that would trigger muscular issues. So we try to respect the physiology of the patients, and we don't want to correct the problems when walking. So this is a more technical concept, but I think it's important to respect the coxa valga on the fish and gluteus medius, because we don't want to give more tension to it, but we want to get the best alignment of the gravity center. So it is important to respect the axis of the bone. So an example to show you the variety of the cases, and especially for a same patient, the arsenal that we have. So on the one hand, we had a weak hip that was fractured, and we were so that the patient could walk again, we had to put in a prosthesis to try to retain the head. And on the strong side, there was also arthrosis. So we tried to have a lateralization with a bigger head and with a rounder bone to have a round curve. So a special case here, that's the polio-PTH. So here, as we can see, it's a minority of cases. For 70% of cases, it's the strong side. We drag our feet when we have to do surgery on the weak side, but sometimes we do when we don't have muscle. So on the capsulectomy, it was a debate: should we respect the capsule or should we do it again? I think that it's better to remove the capsule because it's distorted on very mobile hip, and we should let the fibrosis do its work so as to have dense tissue around the joint. So this is why here we use immobilization hemi-Bermuda that will lead to fibrosis of tissues, what the muscles cannot do in the prosthesis itself. And here I like this image because you see a lot of arthrosis, no muscle on the weak side, but you can see this fascia, which is continuous, and we find this perimuscular structure even with weak muscles, and this fascia lata is an abductor, passive abductor, but it's useful and we have to respect it. This is why I prefer to go through the Huiter pathway. So here on this patient, we can see this fascia that we find when we open up and we see the muscles. So even though the cotil is not perfect, I like to use retentive cotil that can offer the best the best support, but it's a risky case and it's quite complicated. Now, another example of custom-made tissue rod, sorry, custom rod. And amongst the statistics that we find, we had 6 patients that had an equipment before, and only 3 after the surgery. So we managed to have 3 patients give up on their equipment, so 50% of them. The improved amplitudes on the strong side. Not on the weak side, so the hip is a bit stiffer. The Harris score was quite good, and this is the only series in the literature where we have a PTH polio by anterior route. Now, for the knees, some physiology reminder. You know that knee lock without quadriceps requires recurvatum, so equinus or powerful triceps, large powerful buttocks and stable ankle, so knee ankle alignment and stable dowel. So the knees might have unlocking accidents in the knee, and I also wanted to call about pseudo recurvatum rehip plus varus knee. So they walk like this, and the opposite, internal valgus rotation. So we have to analyze the type of knee lockup to see what a prosthesis could do. Can't we have a decompensation of the knee when walking? And we have to consider the ankle very much. So again, we do surgery on the knee and ankle, or the knee, or just the ankle, but we have to consider the whole. In our series 24 knees between 2006 2019, I think that we went even faster since the creation of UPO with François since 2020. I think we did a bit more PTGs annually, and we had a majority of weak quadriceps, and we had a lot of weak quadriceps, almost 40%, no, 50% that had less than 2 out of 5. So it is possible to offer knee prosthesis with people who have weak quadriceps. Now, amongst the interesting statistics, we can see that all the prostheses on the strong side had a gap of length of more than 3 centimeters. So it's not that we want to compensate having more weight on the other side, but in order to maintain the pelvis as straight as possible, many patients were decompensating their knee. Here, the pelvis is tilted and it turned into a valgus. That's just a few years for the same patient with a decompensation and a problem on the other side. Or where you can have decompensation on a fleecum that is flexion deformity with a lot of strain on the joint. There can be serious problems. We had a bit more complications than with the hip. We had early infections when associated osteotomies, and also true external instabilities with hinge recovery. Now, if we were to see these patients again, I think that we would have a hinge prosthesis and one stiffness with mobilization under GA, and even for a weak quadriceps, now we have some stiffness, quite recurrent. So this is something that we have to take into account, and we can also declare that there's been peri-prosthesis, fractures on the small size knees. So we have also anterior femur tibia arthrosis. So we are talking about internal, external, and femur tibia. And so we have this anterior arthrosis, which is rarely identified by radiologists. So here on the profile, you see the condyle that is flattened on the front. So on a face view, you don't see much, but if you do the X-ray with the curvatum, you would see that. So this is arthrosis that is quite specific of people walking with a curvatum. So not having a quadriceps, so we have the joint that is quite low and sometimes more difficult to handle in surgery, and bone hypoplasia depends on these mechanical stimulations. So you sometimes you have some problems with tibia. We have to use micro implants on the tibia so as to put prosthesis on patients who have hypoplasia. And sometimes we also have metaphyseal deformity, especially if they have been if they went through surgery with major deformities. And so there was some functional improvement, reduction of unlocking episodes, and this is linked to the persistence of the post-op recurvatum. So this is not something that is part of the specifications of prosthesis, but we cheat a bit. We try to use the maximum of the prosthesis capabilities to have recurvatum on those knees and to allow locking afterwards. Once again, we had a reduction, or half of the patients had used a prosthesis and as many complications as in literature. So an example of symmetrical affection of polio where the patient have a recurvatum of 30-40 degrees, and we wondered whether we should have something tailor-made that does not exist really for the knee. The industries really don't do that. Or can we still offer some standard prostheses with recurvatum? But the patients said their recurvatum got worse over the past few years, and that the equinus and the ankle could have a less important recurvatum than what he had before. So we had this hinge prosthesis that allows 10-15 degrees of recurvatum, and because we did surgery on both sides, he was symmetrical again and could walk again. Well, regular walk for him. Another example of extreme deformity with subluxation of the knee with a recurvatum where he had surgery with a femur surgery. This is a side view, and then you see the use of the micro implant for the tibia. You can see that it's smaller and the size is adapted to the size of the tibia, and a low patella again. So in conclusion, this is constraining surgery. You have to take into account all the muscles, the joints, the walk, and so on. So with our experience, we got some functional improvements almost all the time. This is quite challenging technically, and the issue now is for implants, prostheses, for example, for the knee, are no longer proposed by the company. They stopped doing them a few weeks ago because there's scarcity pharmaceutics, but also implants. They don't have what they need, so that's a problem. We don't have a prosthesis dedicated to polio patients. The possibility for hip to use tailor-made implants, but again, we have constraints. We have extreme constraints. We had a patient with a femur of 6-7 millimeter thickness, and even the best engineers could not develop a prosthesis that could be integrated to this femur. So I'm talking of all the patients we could do surgery on, but there are some cases where it's better not to do surgery or where there is no possibility of doing the surgery. So of course this work is done in collaboration with anesthesists, the rehab specialists, and the patients, of course. Thank you very much. I think we can give you a round of applause. This was a wonderful presentation. Are there any questions for Fabien? Yes, one there.
Excusez-moi, je suis pas médecin.
I'm not a doctor, but a piece of advice. Could you use the laser pointer to show things? I need to have surgery, hip surgery soon, but I cannot find a surgeon who knows polio patients in my region. So could you give some advice? Yes. These are the recommendations that I make. It depends if it's on the strong side or weak side. Strong side, but even my muscles are weak. Okay, so you should not be too pessimistic. A prosthesis on the strong side is feasible. I don't have the muscular situation, but the conclusion is that it's worth doing surgery, hip surgery on the strong side. There are some constraints. Yes, you have to take into account the inclination, the size, the length. Like I said, you should not try to shorten. Yes, it's on a case-by-case basis, but I think that it's still the best solution to relieve the pain when the indication is good and when it's possible. Okay, thank you. Her question was, can you give advice to the surgeon? So if he were to call you, would he? Yes, I can talk about it with him. Yes. But he does what he believes in. If he thinks the indication is right and what he's offering in terms of implants and procedure, it can go well. This is our experience. The lady is responding off mic. So I don't recommend posterior pathway, but it's a matter of belief, philosophy. You cannot force a surgeon who doesn't know the anterior pathway to do it. The intervention is not the same, the risk is not the same, so. I would like to know if you have many cases of conflicts between prosthesis and psoas. No. Not in our series. The conflicts, psoas implant is something that does exist for hip prosthesis, and sometimes it requires a new surgery to replace the implant or to act on the psoas, but we always very careful for deficit patient to make sure we don't worsen the psoas. Even though this is a surgery possible for psoas profound patients. And good afternoon, Dr. Calé. I remember you. If you have a doubt, go to Garches. You will meet Fabien. This is wonderful because, he did the strong side and the weak side for me. And we signed a deal, and it does work, and I can stand up now. That was advertising. One last question. In 1994, in Rangueil, I had a hip surgery, and Dr. Buget, he unfortunately passed away, and he told me that for polio patients, prosthesis, there was a rejection. It's not a matter of rejection, no. It's a matter of physiology, and a bone that can be integrated with an implant. We don't have more rejection than for another patient, but we have some constraints on length, how to approach it, but yeah. I'm sorry, we have to stop now. Maybe you can see Fabien later on if you have further questions. Thank you very much, Fabien. This was a very good question. We could talk about the other alternatives for arthrosis treatment.